some of those things. I will offer you that Kahoot again if you so want it. The idea is that you grasp on to normal gait terminology, abnormal gait, that you understand the differences between traditional terminology and RLA. Not that there's really a difference, but the terminology or the terms themselves. Identification of what those terms are. Remember, traditional is anatomical. RLA is more timing or spatial. And that is a little more accurate, and I think you're starting to see while we use that. I'm trying to speak more in RLA terms so that you kind of have a feel for that. Really differentiating between the stance phase and the swing phase. And then the other day, we kind of did this number here. We're asking, what are these things doing? And if you go back and you look at either this picture or you go to that video, you can get an idea of what those muscles are doing. It really takes you plotting this out in your brain and saying the dorsiflexors are concentric here, the knee flexors are eccentric here, and I would have some key moments where I would know those. And then we kind of gave a quick analysis. Now, this is not the greatest gait analysis right here. We will spend just a little bit more time and revisit this after we start into the posture concepts in the next week. We're going to go into the lab and look. Actually, we're going to go over to the fitness center and look at someone on a treadmill. And we're going to really break down some of these concepts with you. But knowing that the ankle should be neutral, that the knee should have slight knee flexion. That's not just something that you can conceptualize. You really have to think about, all right, that knee is going to be in slight knee flexion. Where should it be in slight knee flexion? And if they don't have knee flexion, what's that going to alter? Or what if they only have slight knee flexion and they don't have terminal knee extension? What is that going to alter? And we'll look at that here in just a moment. We're going to talk about some abnormal gait patterns. The hips, normal should be 25 degrees. They need 25 degrees of hip flexion for you to have normal gait. Your trunk should be erect and rotated toward the contralateral side. So that means if I'm stepping, I'll rotate away from my step leg, right? And that helps me to lean back. And we'll see that in pelvic rotation here in just a minute. The contralateral arm is forward. What was that called? We gave that a name. Reciprocal. It has to reciprocate that gait. It's really not anything you probably didn't know, but you have to know now, academically speaking, what that is. It's the lateral arm, and again, I put hyperextended. I know that word gets a little nasty, especially when Bill's class is involved. But we're going to use hyperextended. That way you can see, okay, this is moving into hyperextension from that reciprocating gait, right? That's a big part of it. Right there. Now, we did this. Vertical displacement. You saw this on the Kahoot. I walked down. What is the normal vertical displacement?
2 inches.
Yeah, 2 inches. And then we had horizontal displacement. Now, we didn't give that a number because that varies on a lot of different people. But a person will have a little bit of vertical displacement. And I'm just doing some simple weight shifting so you can see. But a person will have a little bit of vertical displacement. And I'm trying to be kind of a little exaggerated with that. Another one that we saw was our width of walking base. Most of the time, that person has a fairly narrow base of support. However, if they have a wide base of support, that means there's probably some balance issues. We're going to look at that here in a minute when we review our abnormals. The toe out was 7 degrees. And then look at what I did here. I put in pelvic rotation, 4 and 4. Now, I want to explain this. If you were to take a transverse view of the pelvis, right here, what you would see is there would be rotation this way and then kind of a counter rotation this way. Now what normal is 4 degrees this way and 4 degrees this way, which gives us a total of 8 degrees. So think about it. As the swing leg advances and I go into initial contact, right? So there's that single limb support, swing leg is coming through. I need about 4 degrees of hip rotation. So you don't really look at this a lot, folks, but I'm going to exaggerate this so you can see that would be a very subtle amount. 4 degrees is subtle, but it's necessary for normal gait. You, the student, you have to put that into long-term memory and know that there's a little, about 4 degrees. And the way I do this is toe out is 7, pelvic rotation is 8. But you have to divide it in half because 4 are going this way and 4 are going this way.
So if that was like do you want us to harp more onto the 4 or 8 part of it? Or just be it like
You gotta know both, buddy.
Okay.
You gotta know both.
I'm thinking more like if the question asked, how much does the pelvis rotate, or you want us to put 4 or 8?
Well, if you just looked at only the question saying how many degrees of pelvic rotation occur during normal gait, you would put 8.
Okay.
If the question said how many degrees occur on the swing limb of pelvic rotation, you would put 4. If it oscillated to a unilateral stance, you'd say 4. But what you have to know is that as one side rotates anteriorly, you're going to get one side rotating posteriorly. So of all that together, you get 8. Does that make sense?
Yeah.
Yes, sir.
Did you update this PowerPoint?
I did touch up, yes.
Okay, because those pelvic rotations weren't on mine from last session. I'll just add it here.
Ready to go forward? Abnormal gait. When we did abnormal gait, we broke it down into 4 things. Now, again, these kind of blend, right? We're trying to give you 4 sequential components of abnormal gait and make this really nice and pretty. The problem is it's not always nice and pretty. But you need to know that these are the 4 primary components. Now, I do not ask that. I don't ask that. What I do is I ask specific things about these. But I don't say, what are the 4 primary causes of abnormal gait? I don't do that. That's not the question. And you're not going to get that probably at licensure level. What you're going to get, though, is what is a painful gait? It's an antalgic gait. What is muscle weakness or paralysis? We're going to look at those here in a minute. What is a range of motion limitation, specifically soft tissue or joint restriction? And then finally, what are some neurological causes of an abnormal gait? So let's go through those one more time so you see them. Number 1 was pain. Pain, we know, is an antalgic gait. That's a limp, right? So here's what you got to know about a limp. They accelerate one phase of the gait cycle. What phase? Stance phase is accelerated. Remember, stance phase was unique. It is the longest of the two cycles, or of the two phases. And we said it lasts how long?
16
Oh, that's going. I don't know why I turned. I did kind of sneeze in my arm. I don't know. It's okay. Lower limb, 60% of the gait cycle is stance phase, right? They're accelerating that. So, we got to know they're, right? We also know that it's lower limb. It's also involved with trunk pain. So think low back pain, but also gut, visceral. They could have visceral pain. And secondary to injury, surgery, illness, and then take a look at that third bullet. Antalgic gait, but could be reduced movement due to all of those things. Any one of them. So, we have to kind of take that into consideration too. If it is a true antalgic gait, they have a decreased stance phase, and then this thing called touchdown, right? Usually if they have touchdown weight bearing, they have an assistive device. Because touchdown weight bearing is largely not going to be an effective gait pattern. Any questions on pain? When we see these two words, weakness, paralysis, most of the time we say, oh, if it's paralysis, they have a neuro issue, like spinal cord issue. I'm not debating that. What I'm saying though is, you'll see many times this word paralysis just attached to the word weakness. And that's all we're looking at here. So just kind of put those two into perspective. We looked at these very specifically on video, and we said that when you have a muscle weakness, there is a unique occurrence that will take place. What did we say to always look for? They move the weight over the weak side.
How does that work with the Trendelenburg though? Because it seems like it's the other one.
It does seem like it, but what you have to look is, where does the movement grossly go to? And so, just so you can kind of see, again, the pelvis here, right? And we had the hips here. Now remember, the glute med, that's your culprit, right? And when it's weak, it lets this complex go this way, this side will drop. However, if you go up the chain, and I'm just going to kind of draw this lightly here, what will happen is this side will come over, but it's subtle. I mean, you really got to watch this one. So when they do, this goes this way. So look here, my center of mass is moving over my weak side. I see the drop over here. It's a pretty subtle thing. You just have to trust what the book tells you on that one. Does that help?
Yeah, a little bit.
I know it's kind of, I have the same, no, it's not the same. I have a really hard time, here in just a minute we'll see crouching gait, because the term crouching to me does not define what's happening. And so I definitely get where you're saying that doesn't always work, but you have to look here down low. The muscle weakness will move over that area. This is the area here. See where my belly button moves to?
Okay.
Is this way. And so that may be some of the points that you want to watch for. Your glute max they're weak here. So what do? We send our trunk posteriorly over those weak muscles. So they do this kind of a, I don't want to use the word lurch, but I want to call it lurch. But they will fall backwards over that weak muscle. There. The quadriceps, I have a quick shift of trunk anteriorly over the knee joint, and I didn't put this in there because I don't want to stir that pot either, but when they shift their anterior trunk, many times they will get a back lock in the knee. They're forcing that knee into extension. What does the quadricep do? It extends the knee. So if it were active and strong, it would take care of that for them. It doesn't, so they need to use their body weight to force that action to happen. The hamstrings is kind of a unique thing. Now, I added this in today. Uncompensated. Here's what happens. The hamstrings are largely eccentric during what component of gait? Let me ask again. The hamstrings are eccentric during what component of gait? Stop thinking about pressure ulcers. Easier said than done.
Is it heel strike?
Right before heel strike. Think swing phase. Heel strike is the first component of stance phase. What's the last component of swing phase?
Terminal swing.
Terminal swing, also known as deceleration. The hamstrings are slowing it down right here. If the hamstrings are weak, this is where you're going to see it. What they do is they have fast extension of the knee during deceleration. Deceleration is a name of swing phase. It's traditional. So when you see that word deceleration, just Rolodex over and say, he's talking about, or the test is talking about, or the licensure exam is talking about the final component of the swing phase. Right here. So what they do is they compensate, I'm sorry, I don't want to use that word. It's not compensated for. I'm having a really hard time because that's not a normal thing to do. But I'm swinging that knee out, using that extension, right? Like that. My ankle dorsiflexors, we talked about that one, and uncompensated as well. So, I have this going on. I don't want to grab this toe. So what do? I have to lift and excessively hip flex, and then extend my knee. That is the steppage gait. If that is a concentric weakness, if it's an eccentric weakness, you're going to hear it in the foot slap. And then we gave a new name to your dorsiflexors. We called them the triceps surae. Did I say dorsiflexors? I did. Ryan caught it. We gave a new name to the plantar flexors called the triceps surae. This is your gastroc and your soleus. And we said when they're weak, that person will not have a heel off or a toe off that's very effective. Right? So their heel off comes from the plantar flexion, then finally the toe off.
Does the gastroc have two heads? Why is it called tricep? Do you know?
Because the gastroc has two heads, a medial and a lateral. Now let's talk about these specific restrictions. I rearranged these two because I felt like it made more sense. The hip flexion contracture and the knee flexor contracture. Most commonly associated together. Think about it like this. If a person develops a hip flexion contracture, that means this muscle has adaptive shortening. Remember, when we said contracture, we said adaptive shortening. That muscle has gotten tight. So you get this. Now, when you get this, most commonly, you also get this right here. So this is tight right here, and these are tight right here. So they stand a little bit like this right here, right? Now, with that, if they only had the hip flexor contracture, you would see the trunk lean forward on stand space. That's here. Right here. When the knee is tight too, you're going to get a shortened step length. Remember, step is from one foot to the next, right? Not from that foot to the next time it hits. That's a stride. So here, why is it shorter? Because they can't extend their knee. Or they cannot extend their hip. Those two things are restricted because of the contracture in the hip flexor and the knee flexor, right? Are we good?
I have a question about Gina Ricker Robin. Are we gonna put that with hamstring weakness or is it gonna be quad weakness?
Everybody hear that question? Because that needs to have a solid answer. And I'm really glad you asked that. 100% of the time, I want you dedicated to that being a quad weakness. 100% of the time. Now, that's not a question on mine. But I will tell you that's a question from Jerry. She will hit you there. I don't know at what level. I really don't. I don't know where you'll get that question from her. But I will tell you, default to the quads every time. The fused hip. And this is largely a congenital fused hip. What they will do is they will have an increased lumbar spine and pelvic motions. Now, this one you've got to just kind of follow me here. I'm not going to do this really good. But they have an increased lumbar lordosis. So here, and this adapts to this fused hip. And what they'll do is they'll swing in the transverse plane more. Right here. Because that hip doesn't flex or extend. And so that's where you're gonna see that. So you just kind of have to say, okay, this doesn't move. What can they still move to accommodate the motion? They can move at the lumbar spine and the pelvic rotation. And that's just the accommodation they have to make. The knee fusion, the ankle fusion, the triceps surae contraction. Remember, these had to do more with the amputee. With this, what we're looking at is knee fusion replicating the idea of a prosthesis. Is the knee necessarily fused? Let's not go there. Let's assume that what's being stated here is that their knee doesn't move. So think prosthesis.
Just have a seat right there and I'll call it.
That means they're going to vault. It also means that they may circumduct. Either or. Now circumduction, what I want you to really put that towards is the hemiplegic gait, which we'll see here in just a minute. But here's your vaulting. They're going to have to excessively plantar flex up, and by terms, vault their leg up and over, just like a pole vault. They're vaulting their leg. You'll see that when Andy comes and he brings his prostheses. The circumduction, they're moving in a circular motion. Why? I'm so sorry, I did not mean to kick your bag. Because of a neurological issue. So let's look at that one. And again, this is where they all kind of come together, right? The hemi gait. Upper flexion, lower extension. So their upper extremity many times is flexed, their lower is in extension. That means the knee, their spasticity, the plantar flexors, their spasticity, and they have to circumduct. They have ataxia. They're going to have poor balance, jerky, exaggerated movements, and a wide base of support. Why? Because where's the ataxia coming from? It's a neuro condition. There is one specific area of the brain where ataxia is really common. The cerebellum. So when you think cerebellum, think ataxia. And by virtue of the word ataxia, think uncoordinated, unbalanced. Or Parkinsonian, or festinating. They kind of lump these two terms together. These folks, they're going to have an anterior trunk lean. They're going to have a flexed hip, flexed knee, a shortened step, and it's almost like someone's pushing them. So imagine someone behind me pushing me. They're kind of getting pushed. And this is kind of what they do. Now, because of the Parkinson's, we're going to just go ahead and assume that there's going to be some jerkiness to that as well. You'll learn that a little bit more in the next semester. But these people have tremors, and so that associates with that movement many times. But a shortened step length is one of the big things that you'll see there. And it's kind of counterintuitive, but they'll have a narrow base of support. The scissor gait, probably have seen that one a lot with our cerebral palsy patients, but that is the spasticity of the adductors. Crosses midline right here. And then notice that it says they have a lateral body shift. Again, as they cross midline, we're going to see this big lateral body shift. Oh, sorry, I'm picking bags like crazy. And then finally, I want to show you crouching. This is another cerebral palsy. And I'll let you kind of look and see these: increased lumbar lordosis, anterior pelvic tilt, excessive hip flexion, adduction, medial rotation, excessive knee flexion, ankle dorsiflex. What a mouthful. Take a look at this thing. And once you see it, you'll say, I got it. Yes, I'll pull it back up here just a second. Let me show you. You'll see it and you'll go, nope, it's there. I got it. Once I see it,
And school
that's
isn't
all
a
it
place
says.
you have to be. Why not go to school where remote learning can be as remote as you want? Like a Verbo.